clinical faculty of the Barry University School of Podiatric Medicine in 2000. She received a doctorate of podiatric medicine from the Barry University School of Podiatric Medicine in 1995 and completed a podiatric medicine and surgery residency at Cedar Medical Center in Miami, Florida. Dr. Brill earned a diplomate as a certified wound specialist in 2016 and is a board qualified member of the American Board of Podiatric Orthopedics and board certified member of the American Board of Podiatric Surgery. Dr. Brill is currently the Director of Residency Training and the Associate Chief of Podiatric Surgery Department at the Jackson North Medical Center in Miami, Florida. So here we have a strong, powerful, resilient woman on this International Women's Day presenting to us on surgical treatment options for diabetic foot ulcers. Please welcome Dr. Brill.
So we're going to again talk about surgical treatment options for the diabetic foot related to diabetic foot ulcers. I have nothing to disclose. I have no actual or potential conflicts of interest related to this program or presentation. So I wanted to share with you a quick video that I thought would kind of lighten the mood this morning. I had listened to Dr. Landano's wonderful presentation yesterday, and she commented specifically on the pre-diabetic situation, which our patients often hear when they go to the primary care doctor. And I just thought this was kind of cute. And I think it does kind of correlate to the way that I see the diabetic foot when it presents to me.
So I'm out of shape. I'm fat. Just got diagnosed with pre-diabetes. Didn't know what that meant, so asked my doctor. She told me, well, that means that you could get diabetes, which is a pretty bad diagnosis because that means everybody in here has pre-diabetes. Yeah. Unless you have diabetes, of course. Sorry about that. Like, thanks a lot. I also have a pre-broken leg. Don't worry about that, though. That seems to be okay. No x-rays necessary.
Okay, so hopefully you guys appreciate the humor in that. I know this is not a humorous topic by any means, but I think the fact that often patients, don't quite understand the pre-diabetic diagnosis, and in some patients even that have been diagnosed with diabetes, feel oftentimes that they are in better control than what they are. And unfortunately, the fact of the matter is whether you are controlled or an uncontrolled diabetic, unfortunately, there are very strong chance that at some point in time in your life, you're going to suffer an ill consequence from that disease process that affects the lower extremity. We've had a lot of presentations over the weeks or over the past week, and I think you guys are very familiar with the stats related to diabetes. But I wanted to talk a little bit more about those very alarming stats that affect the patient's lower limbs in regards to amputation. And it's, alarmingly so, unfortunately, 15% of all diabetics will unfortunately require some sort of amputation in their lifetime. 70% of all non-traumatic amputations are performed on diabetic patients, and 64% of those start because of an ulceration. And, our role here specifically is to prevent these ulcerations from progressing to the point where surgical intervention is necessary, specifically, an amputation related to that ulceration. As we know, 50% of patients that undergo a major amputation will unfortunately require another major amputation on the contralateral limb within 2 years. And that is a staggering statistic that we hope to be able to intervene and prevent patients from progressing down that road. Talking about progression, we have 3 known progressive factors in the diabetic foot. Sensory neuropathy, that loss of protective threshold in leading to the development oftentimes of ulcerations, is the start of this cascade. Patients develop motor neuropathy. That motor neuropathy leads to significant bony changes in the foot specifically, as well as the ankle, and disrupts the normal balance of the foot and leads to abnormal pressures in the foot, and unfortunately worsens those diabetic ulcerations, oftentimes complicating them with the development of a bone infection or osteomyelitis. And in addition to that, unfortunately, diabetic patients often suffer vascular impairment, which leads to healing changes, both of the soft tissues as well as the bone. These are very predictable progressions of diabetes over time. But what is very uplifting is knowing that patient education with compliance, we can educate our patients, but if they're not compliant, unfortunately, the consequences of this process can be extremely devastating. But with good education and compliance, we can definitely change the outcome. And that's what we're here for, right? So patient-dependent factors. I always like to tell patients that they are in control. Patients need to monitor their blood glucose. They need to understand and be educated on what good blood glucose control is. I love it when a patient comes in and they know their hemoglobin A1C. They know what their blood sugar was this morning. If they don't, they're probably not in good control. Vascular-wise, we definitely need to make sure that patients are optimized. The one thing that patients can do besides that glucose control, which greatly affects vascularity, is to not smoke. Tobacco has a huge a poor healing effect on the lower extremity specifically. And that is something that patients can be educated on and hopefully control. The other factor is shoes. We saw a lot of patients over the past week, like Dr. Londano spoke about in her presentation, and the shoe gear was definitely less than optimal. So shoe gear and offloading, good diabetic insoles, good accommodative shoes are very, very important to prevent these ill consequences of diabetes. As a physician, it's really important, or any healthcare provider that is making initial contact with a diabetic patient, even one that doesn't have an ulceration, it's important to monitor these patients progressively. Motor neuropathy is a very devastating, progressive, bony collapse of the foot, and it often starts with the patient reporting a red, hot, swollen foot with no significant trauma related to that. And as the healthcare provider, we need to realize that that presenting complaint may be related to an acute Charcot event, excuse me, an extremely devastating cascade of events that can lead to bony changes and complete destruction of the patient's foot in their normal bony architecture. So what can we do upon that initial presentation? We need to make sure that patients are offloaded. Complete non-weight bearing is optimal, but protective weight bearing sometimes can help prevent that devastating collapse of that arch. The 2 x-rays that you're looking at on the screen, this is a patient that presented with that red hot swollen foot. And unfortunately, you can see here at the tarsal metatarsal joint, the bone destruction is starting. This patient was offloaded, however, not very compliant. And unfortunately, 3 months later, you can see that tarsal metatarsal joint collapse and bony destruction has advanced significantly. We have some AP x-rays here as well, showing you the same patient, just a different view, and you can appreciate the severe subluxation on the right-hand side of the screen. And this, unfortunately, is something that's going to lead to poor balance on the foot. It's going to lead to increased pressure areas, and this patient is going to develop an ulceration. This is a clinical image of the same process. You can see on the right, the arch is almost inverted with a complete collapse. This patient has developed that Charcot joint at the tarsal metatarsal joint, which is obviously going to lead to some significant complications, like you're seeing here with an ulceration in the midfoot area. This patient was treated successfully, conservatively, and unfortunately, because of that poor architecture, this is going to be a recurrent problem for the patient, or one that we have to monitor, excuse me, on a regular basis to prevent potential development of an infection with that ulceration leading to osteomyelitis and then eventually possible amputation. So preoperatively, when we're looking at these types of patients and we're considering surgical intervention, we need to make sure that these patients are medically optimized. We want to make sure that they can mount an immune response to fight infection and heal from that surgery. So a total lymphocyte count, at least greater than 1,500 is recommended. We want to make sure that patients have been evaluated vascularly and that intervention or reconstruction has been performed, especially before some of these major reconstructive cases that I will be showing you. Nutritional status is very important. Pre-albumin, serum albumin levels need to be evaluated and optimized prior to surgery. So in regards to diabetic foot surgery and reconstruction, we have 5 or 4 here, basic principles. We want to control that infection at minimum. We want to localize that infectious process. We want to restore bony alignment of the foot, specifically also addressing the soft tissues. We want to evaluate the patient for an equinus type of pathology and address that equinus surgically if need be with a tendo-Achilles lengthening or a gastroc recession. And I'll show you some of those later in the presentation. In addition, we want to focus on closing the wound. There's obviously a slew of different advanced wound care modalities. We'll touch on some obviously throughout the presentation, but a combination oftentimes of different modalities is necessary to get these wounds to close. And then once we're successful in those interventions, we need to make sure that we maintain that position. Sometimes that requires, in addition to surgical intervention, surgical or post-operative bracing and or accommodative shoes with inserts, all very important in preventing re-ulceration. One of the challenges with these diabetic patients when we have what looks and appears to be a normal, healthy type of ulceration, when it's associated with that bony collapse or that Charcot foot, is differentiating between a bony infection and an underlying osteomyelitis. So we're going to talk a little bit about those challenges. Clinically, there are some things that we can look at that will lean us towards the diagnosis, if you will, of osteomyelitis. So we know clinically if we inspect a wound and we can easily probe to the level of bone, that is a pretty good indicator, up to 98% negative predictable value. So if it doesn't probe to bone, you have a pretty good chance that the bone is not infected and that you're not dealing with an osteomyelitis. But in addition, that probe to bone test has an 87% sensitivity and a 91% specificity for the diagnosis of osteomyelitis. So this is obviously a very easy test that can be done in the clinic or when you're evaluating that patient, trying to determine whether or not there's an associated osteomyelitis. In addition, just looking at the size and the depth of the wound, there was a significant study performed by Newman that showed that if you had a wound that measured greater than 2 centimeters, it had a 56 sensitivity and 92% specificity for the diagnosis of an underlying osteomyelitis. And that also correlates to the depth of the wound. Anything greater than 3 millimeters is going to increase your chance or likeliness of that underlying osteomyelitis. So once we do our initial clinical evaluation, we definitely need to get some initial imaging and labs, and these are some of those recommendations for you. Plain radiographs can be very informative in a patient that does not have an associated Charcot-arthropathy or that joint destruction that I showed you in the initial slides. But unfortunately, if you do have an associated Charcot deformity or a clinical suspicion for a Charcot, it can be quite difficult on plain radiographs to distinguish between an osteomyelitis and a Charcot event. We can use more advanced imaging like an MRI, but unfortunately, again, MRIs are not going to be specific for diagnosing osteomyelitis. In addition, bone scans, the white blood cell labeled scans definitely give us a little bit more information. But if you have an overlying ulceration and an associated soft tissue infection, it again can sometimes be very difficult to differentiate between the two. So that being said, bone biopsy is definitely considered to be the gold standard in diagnosing an underlying osteomyelitis, and definitely something that should be considered in the proper patient. Labs can also give you some information, specifically, as you see on this slide, in a diabetic patient that has an associated foot infection, and we're trying to evaluate for a possible underlying osteomyelitis. We can look at values, ESRs and CRP levels, and the work by Lavery and all that you see here shows a very strong correlation between an elevated ESR greater than 60 along with an elevated CRP of greater than 7.9 is going to give you a very strong likely diagnosis of an underlying osteomyelitis. So something, a very cheap, efficient lab that can be ordered that can help you with your differential diagnoses. So let's talk about a case here quickly. This is a patient that presents to the office. A little bit of swelling, not very significant. You can see that the patient was offloaded. If you look at the bottom of the foot, you can see that a felt pad had been placed on the plantar aspect of the patient's foot. The patient had what appeared to be a very benign looking plantar ulceration. You can see some red granular tissue at the wound center, some marginal maceration around the edges that we were attempting to dry up or to treat that maceration with a betadine type of dressing along with the offloading. And the patient did seem to be improving, but it's months and months of debriding on a weekly basis. And unfortunately, radiographically, very challenging case. So this is, what we're looking at radiographically at the midfoot. You can see the tarsal, metatarsal joint. There's significant bony destruction. You can see some significant osteolysis, which we can see in the early stages of Charcot and is definitely not specific in this particular patient for an underlying osteomyelitis, but nonetheless, very alarming. You can see that osteolysis on the lateral film correlates very specifically to where that underlying soft tissue defect is noted in correlation with that ulceration. So very interesting case and very likely an osteomyelitis. This patient refused surgical intervention. Oftentimes you'll have patients that refuse or perhaps not a candidate for surgical intervention or even for IV antibiotic therapy. And this definitely can create a very significant challenge in treating these patients. So we're talking about controversies in diagnosing osteomyelitis in that diabetic foot. What about taking a superficial culture? This is normally a time where I like to have a little bit of an interaction with the patients, but I think or with the attendees on what you would do for that patient. But I think I'm going to keep talking just so that I can get through this presentation without losing internet connection. So hopefully we're okay and you guys are still hearing me well. So we know, unfortunately, that there is a very poor reliability of the superficial swab. Taking wound cultures in a diabetic ulceration, specifically on the plantar aspect of the foot, oftentimes results in a type of difficult to determine what the infective organism is. It's very important that these wounds are cleansed with normal saline, not an antimicrobial, sharply debrided, trying to remove a lot of those contaminant bacteria that may be present in the wound, and then to get a deep tissue culture. Deep tissue cultures are going to give us the most information. Superficial swabs are not very informative, and really only about 30% of the time are going to identify the underlying pathogen of that bone infection. Again, MRIs that we mentioned before, very high sensitivity, but specificity is very low because of the patient that has an associated Charcot or neuroarthropathy condition going on in the foot. So bone biopsies, again, are the gold standard. Antibiotics, if possible, especially if the patient is not septic or severely ill because of the infection, those antibiotics can be deferred until biopsy can be taken. It will definitely improve our yield in identifying that underlying infective organism. The lack of culture data, if we are unable to obtain a valuable culture, unfortunately can lead to the unnecessary broad spectrum antibiotic regimes, obviously increasing risk of adverse effects to our patients, and oftentimes can lead to therapeutic failure. So, duration of treatment for those biotics, if the patient is not a surgical candidate or inadequate bone resection of that infectious material cannot be performed, we definitely recommend 6 weeks of IV antibiotics. Oftentimes, if surgical intervention is performed, and we have negative margin biopsies once the infected tissue is resected from the wound bone as well as tissue. And we take a clean margin biopsy after that resection. If it comes back clean, only 3 to 5 days of postoperative antibiotics are necessary if there's a remaining cellulitis in the soft tissues. If not, if there is no remaining cellulitis, oftentimes 24 hours of post-operative prophylaxis is sufficient. So it's really important to get those clean margin biopsies. And we'll talk about that as we go through the presentation as well. If clean margin biopsies were forgotten, oftentimes these cases are long and tedious, and oftentimes I hate to say, but sometimes a clean margin biopsy may not have been performed. And in that case, again, we're going to recommend the 6 weeks of antibiotics. Diabetic foot infections associated with osteomyelitis may only need 3 to 4 week course of antibiotics based on some small cohort studies. So is 6 weeks absolutely necessary? that gold standard is definitely being challenged with many scientific studies currently. So in addition, challenging that IV antibiotic 6-week regime is the utilization of oral antibiotics. And it's definitely something that we can consider in patients that are hemodynamically stable, and that we definitely feel that we have an adequate control of that infectious process. The patient, we are confident that the patient can absorb that oral medication with normal functioning GI tract, and that the antibiotic that is being used orally has adequate coverage for that underlying pathogen. So very important. And then, of course, we need to take into account that there's no psychosocial reason that exists that would preclude the safe utilization of that oral therapy. So patient compliance is an issue with oral antibiotics as well. So here we have a patient that he had a amputation of the hallux due to a gangrenous infection of the great toe. He did quite well for a significant period of time. And then unfortunately, because of his neuropathy and the imbalance in the foot and increased pressures underneath this first metatarsal, you can see that broke down again. He developed an abscess. That abscess, you can see tracked underneath the web spaces of digits 2 and 3, and this chronic ulceration ensued. So we did everything that we can. We went back in and we resected a portion of the metatarsal, which was creating a bony prominence on the inner surface of the foot. With the resection of that first metatarsal, we now have increased the load-bearing pressures to the lesser metatarsal areas, and then he subsequently began to break down underneath the second metatarsals. And this is a common scenario, obviously, that we see with patients. We heal wounds, and unfortunately, oftentimes the initial wound will reopen, or surgical intervention was performed on one area and the subsequent area then breaks down. And, it's oftentimes a long, exhausting effort to heal these wounds, but it is so incredibly important. This slide was put here just to show you why we spent so much time and effort and to healing these wounds, was because the patient had already suffered a show parts amputation on the contralateral side. So we want to do everything that we can to preserve this limb. And every patient has specific scenarios that we need to respect and do what we can individually for each of them. This is a patient that had diabetic ulceration underneath the first metatarsal. You can see that ulceration is quite deep. It definitely probed to bone. You could easily palpate and almost visualize the sesamoid bones underneath the first metatarsal. So this is an obvious osteomyelitis. There's no need for advanced imaging. In this particular case, the bone is exposed. It is clearly infected, and surgical intervention for this patient is definitely warranted. If you look at the top of the foot, it doesn't look so bad, but looking at the bottom of the foot and realizing that the bone is exposed, this is definitely a case for surgical intervention, and that's exactly what we did here. So radiographically, it appeared that mostly the base of the proximal phalanx of the great toe, as well as the head of the first metatarsal, were involved, and so those areas were resected. All the soft necrotic bone was taken out of the wound. You can see that we did not go plantarly through the ulcer site. We chose a secondary incision, which is recommended for that definitive resection. And so that's what we did here. We went in through a secondary incision on the medial aspect of the foot. Infected bone was resected. And what you see here is the resection of those clean margins. So we are resecting enough bone to where we get clean, healthy, hard bone that hopefully will be sent to the pathologist and will come back as a clean margin so that we can really tailor his post-operative antibiotic regime. So after that bone was resected, copious saline irrigation is performed, and then those cultures, as well as bone being sent to the pathology. Again, these are clean margin biopsies. You can see that there is quite a defect left after that resection. This is a common practice of a polymethyl methacrylate bone cement being mixed with an antibiotic powder for antimicrobial effects. So these little beads can be made on that table with the bone cement and the antibiotic powder mixed in, and it allows a direct delivery of antibiotics to that surgical site. This can be done as an adjunct to that oral or IV antibiotic that the patient is to the surgical site. As you know, many of these patients are not hemodynamically stable, and we always question whether or not our antibiotics are getting to the surgical site. And so this is a way that we can ensure that the bacteria is being treated to the best of our ability. So those antibiotic beads were left in place for approximately a month and then removed. And you can see that fortunately this patient's wound healed rather well, and he did well for quite some time. Unfortunately, because of the defect of bone here, that hallux did retract, and the patient, I don't think I have the pictures here because I needed to shorten the presentation, but he then did subsequently develop an ulceration underneath the second metatarsal. And so he eventually did end up getting a transmetatarsal amputation, and he's been stable for more than 15 years with that transmetatarsal amputation. So we did everything that we could, and we were definitely able to save that foot for quite some time, but eventually he did go on to a more proximal amputation. This is another patient with a chronic ulceration on the plantar aspect of the foot, again, due to a Charcot collapse of that rear foot. You know, looking at this patient radiographically, the foot is quite plantar grade. It seems to have a good support surface, but you can see a very significant bony exostosis that formed in the area of the cuboid, which is creating this ulceration. And so I put this slide in to let you know that, you know, we don't always do the big reconstruction on some of these diabetic patients, especially those that are not as medically stable as we want. A simple exostectomy or planing of these bony protuberances is sometimes very effective in healing these wounds. And that's what we chose to do in this particular patient, was resect this bony prominence and, of course, advanced wound care modalities to the ulceration. And he went on to heal pretty uneventfully. Obviously, once that wound was healed, he was placed in an accommodative insole with a diabetic shoe to maintain that balance on the plantar surface of the foot to help prevent re-ulceration in the future. So here we have another patient that has ulceration and medial arch, again due to underlying Charcot event affecting the tarsal metatarsal joint. Just a quick case showing you how the arch is basically inverted and collapsed. And so there are oftentimes surgical reconstruction that can be done to that bony collapse to reestablish that arch. Here we're doing a medial column fusion where we are fusing and stabilizing that first metatarsal cuneiform joint to reestablish that arch and alleviate those pressure points on the plantar surface. We chose to do a medial column fusion, so resecting the cartilaginous surface at the base of the first metatarsal in the medial cuneiform with a plate and screw construct, fusing that medial arch, reestablishing that arch, and eliminating those plantar pressures that were leading to that ulceration of the medial arch. In addition to that, a tendo-Achilles lengthening was performed. I cannot emphasize the importance and the ease of this procedure. You can see here, these are very small stab incisions that are done at the distal aspect of the Achilles tendon. And those small stab incisions can lengthen the Achilles tendon very non-traumatically. I can perform this procedure even if I have a patient that has an infected plantar ulceration with little fear of seeding infection proximally. Definitely something I would recommend you evaluate your patients for as potential candidates. This procedure eliminates a tremendous amount of force on the surface of the foot. Alleviating the pressures obviously is going to allow those plantar wounds to heal more efficiently. So definitely something that you can consider. This is that patient's arch reestablished. It's obviously not pretty. You can see there's still some bone destruction around the tarsal metatarsal joint, but the alignment of that foot has been restored, and hopefully that patient can go on to heal. Without restoration of that arch and complete collapse with that associated Charcot deformity, these are obviously very common wounds that I saw during my time in the Bahamas, and obviously here in the States as well. This is not unique to any area, but definitely something that is unique to that poorly controlled diabetic. And oftentimes as well, even in the controlled diabetic, we see this happen. And so these are those very interesting cases that require very significant reconstruction. And so here you can see that the patient's subtalar joint is completely dislocated. You can see that the talus is basically sitting next to calcaneus. This is a lateral subtalar joint dislocation. You can see when we look at that clinical image, the patient's foot is completely off to the side laterally, confirming that dislocation of that rear foot joint. And so in order to alleviate the pressures in this area and in order to get this wound to heal, we need to do a very significant bony reconstruction, again, in the patient that's medically stable and in the patient that has the resources to go through this type of procedure. But I did just want to share some of these with you. So this involved both internal realignment of those bony structures along with maintenance of that new position or that corrected position with an external fixator. These are commonly utilized in those diabetic patients with significant bony collapse and destruction of those arches. So here you can see that first the frame is put on. There's multiple rings that are attached to the lower leg, as well as attached to the foot and then attached to one another. And the goal is to get that foot back underneath the leg. At the same time, we're able to offload the plantar surface of the foot. And you can see here that the patient's wound is being treated with a wound vac. This patient had a bone biopsy performed at the same time. Originally, a bone biopsy was performed to make sure that there was no associated underlying osteomyelitis. That bone biopsy was negative. We opted for reconstruction, but at the time of the reconstruction, again, additional bone biopsies were taken just to confirm the need for long-term antibiotics in this patient during this healing process. So fortunately, that was not an issue for this gentleman, but definitely something that could be implemented if necessary. So the wound is offloaded, a wound vac is placed, and we are performing multiple debridements, multiple adjustments of the frame, again, to get that fit underneath the leg and hopefully eventually be able to heal that wound. I have a preoperative clinical image of that patient. Here you have a postoperative image. We're not quite done, but you can see that the arch has been reestablished. There's obviously some redundant soft tissue, but no bone in this area anymore. And eventually this will, the swelling will go down in that area, and we are continuing to treat that wound. Eventually, we're able to get the foot underneath the leg, and the wound is completely healed. And this patient is going to, again, be braced and offloaded with accompanying AFOs, orthopedic shoes, and inserts to prevent this from breaking down again in the future. This is that patient's x-ray again preoperatively, again, just showing you the position of that talus. You can see that the talus was the underlying etiology, or the subluxation of that talus was the underlying etiology for that large ulceration. And now you can see that the calcaneus is back underneath the talus, and the talus underneath the tibia. So again, it's not pretty. The architecture has definitely been destroyed in this foot, but the alignment is adequate for this patient to hopefully live and maintain his limb throughout the rest of his life. Unfortunately, it's not always the case, and we do need to resort to some sort of an amputation. And so I'm going to talk a little bit about determining potential levels of amputations. It's very important that we attempt to perform the amputation as distal as possible, ensuring that that distal amputation site is capable of healing. We also want to consider the functionality of that amputation level. And one thing that I have learned and have grown to respect greatly, despite all vascular intervention, despite all vascular evaluations, I send my patients to the vascular surgeon for clearance, and they are oftentimes able to guide me in the level of that amputation based on what they see circulation-wise. But honestly, bleeding at the time of that surgical incision for me is the most significant predictor that that wound is going to heal. When you make your skin incisions, if you do not see bleeding at the time of that incision, that amputation site is likely going to dehisce, and failure, unfortunately, may result from that. So if you have no bleeding when you make your incision, you may need to go a little bit more proximal. It's very important when you consent these patients for surgical intervention that you include a statement about the potential for a more proximal amputation or debridement, because oftentimes you don't always get what you're hoping for in the operating room. Obviously, we're trying to avoid this. We don't want patients going on to a below the knee amputation or an above the knee amputation. We realize specifically in our diabetic patients that often have concomitant cardiac issues that the amount of energy expended in walking with an above the knee amputation is 65% increase compared to a patient that has both extremities. So that puts a tremendous amount of stress on that patient, and oftentimes can lead to a devastating myocardial infarction, and often even lead to death in a patient. So we want to avoid these more proximal amputations if possible. Interesting stat that a bilateral below the knee amputation has a 25% less energy expenditure than a unilateral above the knee amputation. So if we do need to go proximal, we definitely want to go below the knee if possible. So intraoperative considerations for these foot amputations, we definitely want to make sure they eliminate dead space. A lot of times we're dissecting a significant amount of bone and soft tissue. We don't want to close under tension, and we want to make sure that under those layers of skin that we close and avoid any type of hematoma or seroma formation, which can obviously. But when we are performing these amputations, we want to make sure that we are eliminating dead space associated with the resection of those tissues. If there is a significant dead space, we want to make sure that those areas are packed and that we allow for some sort of drainage. We don't want hematoma or seroma formation, which we know is just a great median for bacterial growth. So elimination of dead space is key. We want that we use fine, non-reactive type of skin suture that typically is nylon, Prolene, or even staples are very effective in skin closure with a lot of these amputations. The absorbable types of sutures, the braided materials, unfortunately, can also harbor bacteria and should be avoided. Minimal tension at wound margins. If it's tight, and you see that with suture that is blanching, then that is too tight. You need to refashion your amputation site so that those skin margins are not devoid of circulation or capillary fill at that time. So you definitely want to make sure that you have good capillary perfusion at the skin at your stump closure sites. In addition, we want to pay attention to muscle function. With some of these more proximal amputations of the midfoot, we want to preserve tibialis anterior and the peroneus brevis on the lateral side, tibialis anterior on the medial side to help prevent that very common equinovarus pathology that can result after some of these more proximal amputations. Let's see okay. We want to section nerves sharply. We want to make sure that we cauterize blood vessels again to avoid those hematomas, and we want to avoid any bony prominences. So these are some common amputation locations or levels in the foot. From toes, metatarsal phalangeal joints, transmetatarsals, amputations. This is an amputation that has a very high success rate and one that I highly recommend. Going back real quick, different levels of amputation of the foot, all the way from the toes, transmetatarsal, Lisfrank's joint, show parts, and even the Symes amputation. These are all amputation levels that should be considered in patients prior to that below the knee or above the knee amputation. Of all of these amputations, tarsal or transmetatarsal, in my opinion, is the greatest longevity. Providing patients with a stable foot, with a good outcome. But I am going to show you some other. It's really hard to convince a patient that has this foot presenting like you see on the screen that they need to do a complete transmetatarsal amputation. The rest of the toes are great. Obviously, the hallux is gangrenous. We have a dry gangrene here, and we need to consider an amputation. Do we do an isolated hallux amputation or do we do a transmetatarsal amputation? I guarantee you the patient is going to do better with that more proximal transmetatarsal amputation. But again, sometimes it's hard to get patients to see that in the big picture of things. But I always do my part, and I let the patients play a very important role in that decision-making process. And if they want to do that toe amputation, but I'm going to educate them on the fact that they may need a more proximal amputation at a later date. So these do have a pretty good success rate. Unfortunately, in the diabetic patient, I think that success rate goes significantly down. You can see here that we did the toe amputation as the patient wanted, but unfortunately, there were some ischemic changes on the dorsum of the foot. Dorsolatus artery was not as patent as you had hoped, and you can see the very clear distinction between necrotic SGAR2 that is typically perfused by the deep peroneal artery, which was not functioning as well as the posterior tibial artery, which supplies circulation to the plantar aspect of the foot. Beautiful capillary fill time on that flap planarly, but obviously significant destruction on the dorsal aspect of the foot.
Okay, we do have a question for you in the comment section. The question is, in a case like this, where there may be some ischemic changes, is leech therapy an option?
So, I have very limited experience with leech therapy. Leech therapy, honestly, is not for arterial insufficiency. Leech therapy is more for venous congestion. That's really the only clinical scenario that I've used it for. So in my opinion, no, leech therapy here would not be good. Maggot therapy, on the other hand, may be an option to help debride this necrotic ischemic tissue. So maggot therapy, yes. Leech therapy, no. Leech therapy should be reserved for venous congestion scenarios. But again, I don't have a ton of experience with that. So clinicians, it's important to recognize when these patients would benefit from surgical intervention. It's always a challenge in that medically unstable patient. There are oftentimes situations arise where we really have no other choice because obviously of a bacteremic or septic type of condition has resulted in wounds, infections that follow suit. Digital amputations are quite simple and something that can be done without significant stress to patient. Oftentimes, these patients are completely neuropathic, as you know, when you debride these wounds, and they have absolutely no response to pain of the blade. And so surgical resection, digital amputations, and even complete forefoot amputations and transmetatarsal amputations can be done under local anesthesia or with no anesthesia whatsoever. I would like to caution you on multiple ray resections, so meaning amputations of the digit and the metatarsals associated with those digits. You may be better off doing a more proximal transmetatarsal amputation. Has a much higher success rate. These slides that you are showing you some of those cases. Skin grafts, harvesting skin grafts from the patient. Autogenous skin grafts can be very effective in closing some of these wounds, replacing defects after soft tissue resection has been performed. I guess I'm going to go ahead and end it there to.
Well, thank you. Thank you so much, Dr. Brill, for taking time out of your schedule to share with us on this very, very important topic. Unfortunately, diabetes is a medical condition that is extremely prevalent in the Bahamas, and we have encountered many, many, many patients who would have suffered the devastating effect of having a diabetic foot with subsequent amputation of one or both lower limb. So this information is definitely very important, and I am sure that all of the participants who were here today are grateful for the information that you have imparted to us.